Hello, everyone. I'm Leonel August Rodriguez, the VP of Business Development for Access Medical Labs. I'd like to thank everyone for joining us on another Access Live, where we bring you insight from leading medical experts. We do ask that all questions are submitted via the Q&A, as they will be answered at the end of our lecture. So today we have a very special individual. She is the co-owner of Restoration Healthcare, the CEO and the founder of BioPellet Consultants. Without further ado, live from Arkansas, Dr. Kelly Hopkins. How are you, Dr. Kelly?
I'm good, Leo. Thank you for that wonderful intro. I am in the South, so I'm sure that will be evident with my accent. But we do what I'm about to talk to you about. We do this in our office every day, and we have a combined experience level of about 30 years. And what I'm going to teach you today is something that will work for 80 to 90% of your female patients. So if you are just beginning to do hormone work, it can be overwhelming if it's not something you have a deep knowledge of, but hopefully what we learned today will be something that will be helpful. We're going to stay out of the weeds. We're going to keep it simple, and we'll just get started. So the mystique of female hormone balance can be daunting. And when you're looking at your female patient, you're going to need to look at a couple of different things. What is their general phase of health? Are they dealing with a lot of comorbidities? Are they is their lifestyle active or sedentary? Just understand what they've already got going on, and then acknowledge stress levels. Is this a high level CEO, or is this a busy mother of 4 kids, or are they taking care of aging parents? Just understand their stress levels. And then take a look at their nutrition. Have them list out what is an honest assessment of their daily diet. And are they craving salt and sugar, things like that? And then what is the current phase of hormonal life that they're in? Are they in their 20s, in their fertility stage, or have they moved towards perimenopause or menopause? So as we're looking at the general health of the patient, what we have to look at is several different parts of the endocrine system. The ovaries, of course, is going to be the biggest piece of it. The ovaries produce our estrogen, progesterone, and testosterone. And females do make 10 times more testosterone than they do estrogen during the fertility years. That's not a common known thing. And a lot of your female patients will not understand that testosterone is actually a female hormone. We make about 10% of what a male makes, but it's definitely important. And then what our adrenal health? Our adrenals are the backup system to our female sex hormones. They do a lot of other things, but if you have your patient that is stressed and going through menopause, she's really going to be running on empty. But the adrenals produce pregnenolone, which is considered the grandfather hormone, and then from pregnenolone, we can derive progesterone, DHEA, testosterone, and estrogen. The adrenals also produce our stress hormones, cortisol and adrenaline. And then we look at thyroid function. Is the patient adequately converting T4 to T3? Does she have Hashimoto's? We're going to talk about all those things in just a bit. We also have to consider their gut health. This is where all of our micronutrients are absorbed in the small intestine. This is where 80% of our serotonin is produced. And a high sugar diet along with estrogen dominance can produce a lot of candida yeast. So if we're taking in a lot of good foods and supplements and things like that, but our gut's not healthy or we have leaky gut, then we're not going to be able to utilize those micronutrients. You have to look at their pancreas and their insulin sensitivity. Is their glucose out of control? Are they storing it as fat? There are things that we can look at and do for those patients that may not be diabetic, but there are certainly a pathway that we can send them down that will help increase insulin sensitivity. And of course, if you have good use of your glucose, you're going to have good energy levels and things like that. The pineal gland is also important when it comes to sleep. As we age, we produce less melatonin. We are not able to get into those deeper REM stages of sleep. So this is where you ask your patient, do you sleep well? Do you dream? And that's something that will need to be assessed as well. Then, of course, the liver. Oops. The liver is key for metabolizing excess hormone. A fatty liver can certainly contribute to estrogen dominance, and there's a lot of good liver cleanses that are helpful in achieving hormone balance. So let's talk about hormone cell receptors. Just as a review, there are receptors that exist in the cellular membrane and the cytoplasm and the nucleus of most cells. And most hormones have a hormone that works in opposition to the other one. It's you can liken it to having one foot on the gas pedal and one foot on the brake pedal. A good example of this is estrogen and progesterone. Estrogen can create good cells and bad cells indiscriminately, and progesterone comes along and creates cell apoptosis or appropriate cell death. So a lot of anything estrogen creates that's undesirable, when you have a good dose of progesterone, that will really clean up a lot of that bad cells and tissue. And then we know that cell receptors initiate all cellular activity, whether good or bad. And this is just a diagram of a hormone locking into the receptor in the cytoplasm of the cell. And then that, of course, causes a signaling response. So let's reacquaint ourselves with what the normal female menstrual cycle looks like. Day one of week one will be when she starts her period. And then you can see, if you follow the red line peaks about mid-cycle. When you have this nice high peak of estrogen, that's when you ovulate. And after you ovulate, then estrogen decreases again. But the yellow line is progesterone, and you can see that progesterone really peaks after ovulation. And then testosterone is the blue line, and it peaks around ovulation to help drive libido and the chances of getting pregnant. So having an understanding of this cycle in this diagram really will help you help any of your female patients. So we know that during our phases of life, we have a reproductive phase. We're producing lots of estrogen, progesterone, and testosterone. And then we have a perimenopause phase where we start to have estrogen dominance, meaning we might have a peak of estrogen where we ovulate 1 month, and the next month our estrogen doesn't get up as high. We don't release an egg, we don't ovulate. And so then you're not going to have a big surge of progesterone. And testosterone seems to take a nosedive in somewhere between the ages of 20 and 40. So therefore that keeps you in estrogen dominance. And then the menopause phase, where we have little to no sex hormones at all. Even our estrogen has decreased. So this is another diagram of a woman's life in hormones. And by our mid-30s, we've lost 50% of our testosterone, and we may only ovulate 30 to 40% of the time. Thus, that's going to give you no progesterone. And then by the mid-40s to 50, there is no testosterone or progesterone and decreasing estrogen as the female heads towards menopause. So the stages of female hormone fluctuations, these are the things that it can cause. For our 20s and 30s, we're going to start dealing with infertility, PCOS, menstrual irregularity, and those are the patients that are typically going to be on oral contraceptives. In the 30s and 40s, we're dealing with decreased libido, menstrual irregularity, weight gain, PMS, PMDD, and MS. I put MS in there because once we start to lose our progesterone, there are progesterone receptors on the Schwann cells that make the myelin sheath that goes, all around our brain and all of our nerves. So, if nothing else, most of our MS patients, the disease process comes along in mid 30s and above. So, if nothing else, the lack of progesterone exacerbates MS for sure. In our 40s and 50s, we have all the above, plus hot flashes, night sweats, mental fog, depression, fatigue, endometriosis, fibroid tumors, and breast cancer. In our 50s and 60s, we have all that, plus cessation of menstruation, and typically hysterectomies, ablations, things like that. And then our 60s to 80s, we have all of the other stuff, plus heart disease, osteoporosis, Alzheimer's, and cancer. So I just want to point out, this is Access Medical Labs Comprehensive Female Panel Plus. It is a fantastic panel. It covers all the bases, and it is typically what we would recommend that you do for your patients. If you're not familiar with it, this is, the CBC with differential is going to help you know if they're fighting infections. The comprehensive metabolic panel, of course, you're looking at blood sugar, kidney function, liver function. Lipid panel, free T3, free T4, TSH. The DHEA helps show you the DHEA and cortisol help show you the health of the adrenals. DHT is dihydrotestosterone. That's helpful for your patients that once you put them on testosterone, if they convert to DHT, that's the number you're going to want. Sex hormone binding globulin typically goes up when our serum levels of testosterone go down. And so if you're having trouble with getting enough free testosterone, it's good to know that SHBG number. Of course, estradiol, LH, and FSH. We really look at FSH when we're dealing with our perimenopause patients. FSH climbs as estrogen goes down. And the thing about when you draw labs, you know that patient's estradiol level that moment you drew her lab. But if she's perimenopausal, you're going to see a rising FSH because it does give you a bigger window of that patient's estrogen need. IGF-1, that helps you look for growth hormone. We do some peptide work in our clinic where we'll use Simorelin, Ipamorelin to help get that insulin growth factor up. Then CRP, ferritin, estrone, testosterone free in total, and then progesterone. And then you have hemoglobin A1C and estriol. And vitamin D is also a big one. So let's briefly talk about the difference between bioidentical versus synthetic hormones. I'm going to start this conversation by saying all hormones we use today are made in a laboratory. However, bioidentical hormones are the exact same chemical structure that patients are born with. So they typically will come from plant material. That plant material is taken to a lab and converted into the exact molecule of estradiol, testosterone, and progesterone. The synthetic hormones are altered just a bit, and what they will, they're similar, they'll do similar things to bioidentical hormones, but they can cause life-threatening side effects because they can interfere or block proper hormone receptor function. And this is a good example. This is a progesterone molecule. You can see here that the one on the left is the natural human progesterone, and the one on the right is synthetic or medroxyprogesterone acetate, brand name Provera. And you can see there that they've added some methyl groups and things to alter the structure just enough. And, the main reason is you cannot patent the natural progesterone molecule, but you can patent the medroxyprogesterone acetate. And patents equate to financial gain. So let's break it down a little further. In our 20s and 30s, those girls are dealing with irregular menstruation due to stress, poor nutrition, maybe weight loss, and they're definitely not ovulating most of those times if their periods are irregular. Polycystic ovarian syndrome, you're dealing with insulin resistance, a lot of processed foods. There's typically a high testosterone level, and they are also not ovulating effectively. And then infertility, they're definitely not ovulating. Their estrogen is probably low. And once again, remember the Comprehensive Female Profile Plus. Please try to do that test during the luteal phase, days 16 through 24 of the menstrual cycle. And then we always like to add B12 and folate. So treatment for these 20s and 30s, if it's a regular menstruation, have them stick with a whole food diet, methylated B vitamins, just in case they are ones that have the MTHFR methylation break. Then we do 100 milligrams of micronized progesterone or 10 milligrams of compounded progesterone cream, and we have those girls use it days 14 through 28 of their menstrual cycle. And what that will do is that will get them going in a regular rhythm. And if they'll do that 2 or 3 or 4 months, it really does get them on the path to a regular menstrual cycle. If they have PCOS, definitely need to get them on a ketogenic diet, possibly intermittent fasting. We once again use 100 milligrams of micronized progesterone or a 10 milligram compounded cream. Once again, days 14 through 28 of the menstrual cycle. And then we will add 500 milligrams of metformin ER or 1,000 milligrams of berberine daily to help increase their insulin sensitivity. But they really have to do their part with the ketogenic diet. If it's infertility, we'll do adrenal testing. A lot of these girls are going to be on Adderall. We try to get them to reduce that dosage because Adderall is an adrenal stressor. And it's when the body's in a stress state, it's not going to want to bring a baby into the world. So adrenal testing, whole food diet, methylated B vitamins, and then once again, the progesterone days 16 through 28 of the menstrual cycle. You want to wait till day 16 because you don't want to suppress ovulation. You just want to add to it after they have ovulated. If your patient is on oral contraceptives, what you can do for those girls, of course, the OCPs are going to control ovulation because it minimizes estrogen and progesterone. But a lot of these women will talk about having fatigue or weight gain or depression. What we do for those girls is we do treatment with 10 milligrams of testosterone cream that is compounded, or we use hormone pellets in our office, and we will use an appropriate testosterone dose in the form of a pellet every 4 months, and then methylated B vitamins. In our 30s and 40s, the etiology of our hormone imbalance the testosterone will drop and the estrogen begins to fluctuate. There's decreased ovulation, and that causes a drop in progesterone. And then high stress levels result in low DHEA. And once again, DHEA is important because it is the precursor to our estrogen and testosterone. The symptoms of the 30 and 40-year-old will be low libido, fatigue, mental fog, weight gain, sleep issues, depression, PMS, PMDD, and sometimes MS. In the 30s and 40s, what we're going to do for testing, once again, the Comprehensive Female Panel Plus through Access Labs, and also get a B12 and folate level. The treatment is going to be a 10 milligram compounded testosterone cream or an appropriate pellet dose. But our goal is to get that female's testosterone level between 80 and 120 in GDLs. And that is outside the reference range on most lab values, but it is where the females feel the best. We'll do 100 milligrams of progesterone in a capsule or a compounded cream, 10 milligrams. And these women will go back to using it days 14 through 28 of the menstrual cycle. We add 1 to 3 milligrams of DHEA daily. We'll do methylated B vitamins daily and 500 to 1,000 milligrams of berberine daily if their A1C is high. We also add 100 milligrams of DIM, diindol methane, to most of our females' protocol. That helps with estrogen metabolism. So in the 40s and 50s, our testosterone is non-existent by this time. Estrogen really is beginning to sputter, and ovulation results in no progesterone. High stress, once again, results in low DHEA. There's a decrease in melatonin affecting our sleep and a decrease in stomach acid. As we age, we don't produce more of anything. We only produce less of everything. And then you have the symptoms there. The no libido is a big one. Heavy bleeding, clots, the frequency of the menstrual cycle begins to be unpredictable. You also have some hot flashes, night sweats, mental fog, sleep issues, indigestion, depression, endometriosis due to that estrogen dominance, and fibroid tumors, and even breast cancer really starts to show its ugly head in the 40s and 50s. So once again, for testing, use the Comprehensive Female Panel Plus, B12 and folate. And then treatment will be a 10 milligram testosterone cream daily or an appropriate pellet dose. We add 1 to 2 milligrams of compounded biased cream or a capsule, and we will typically do an 80-20 mix of estriol to estradiol, simply because that's the ratio Mother Nature has it. But a lot of people will use a 50-50 biased cream or capsule. Or we will use an appropriate pellet dose. A 6 milligram pellet might be okay for this female. She's still producing some of her own estrogen. So we just kind of start her there. Our goal with any estrogen we give a patient is to keep their FSH below 23. And then once again, we will use progesterone days 14 through 28 of the menstrual cycle, or if they've had an ablation or their cycles are erratic, they don't have one every month, then we will just have them do the progesterone 2 weeks on, 2 weeks off. And this is a good time to bring up hormone cell receptors and the fact that if you give estrogen, testosterone, and progesterone constantly, all the time, what that tends to do is dull the receptors for those hormones. When you can give the progesterone in a 2 week on, 2 week off basis, what that does is it helps create the excitement for the estrogen receptors, and the hormones are just more efficient. I use a silly example of if you ate dill pickles every day, all day for 30 days, the receptors on your tongue are going to be less uh, uh, acute for that pickle taste at the end of that 30 days. And it's just another example of receptors getting burnt out. So just another reminder, between the ages of 20 and 45 or so, testosterone takes a dive. We quit ovulating, so our progesterone nosedives about mid-30s and beyond. And then estrogen's the last to go. It hangs on pretty good until we're in our 50s. But you can see this is a good example of how estrogen becomes the dominant hormone as we age. So 40s and 50s, the treatment continued. We will add the 1 to 3 milligrams of DHEA for our adrenals, methylated B vitamins, vitamin D3 if needed, and then 500 to 1,000 milligrams of berberine daily if the A1C is high, 100 milligrams of DIM daily, and then 1 to 3 milligrams of melatonin. And then if they're dealing with indigestion, we will have them add a hydrochloric acid tablet 30 minutes before meals, just to help increase the stomach acid so the food is broken down. In the 50s and 60s, our sex hormones have declined completely. We are definitely in menopause. High stress means we have low DHEA, low melatonin, and low stomach acid. And then, of course, all the typical symptoms of menopause there. So here's how we treat. Of course, we're going to use the Comprehensive Female Panel Plus with B12 and folate. And then we're going to use our testosterone in a cream or a pellet. We're going to we'll start with 1 to 2 milligrams of bias in a cream or a capsule, or do an appropriate pellet dose. A pellet dose will typically start at about 12.5 milligrams and go up from there. We do try to keep our testosterone, when we're doing pellets, we keep our testosterone to estrogen ratio in a 10-to-1 ratio, or as close to it as we can. For example, if we're giving a female 12.5 milligrams of estradiol, we will do 125 typically in or more for testosterone. And that keeps it in the ratio that Mother Nature, had us producing in our 20s. We will use progesterone. We will either do it daily with these patients. They are not interested, if they have a uterus, they're typically not interested in having any bleeding or spotting. However, we will always manage our patients ahead of time and say, if we are giving you estrogen, there is a possibility, and it is a youthful response for your uterus to possibly build up a lining that has to be shed over time. So we handle the freakouts from the beginning. However, if they have had a hysterectomy or an ablation, we will still try to do the progesterone in the 2-week on, 2-week off, just to keep the receptors more excited. We use DHEA, methylated Bs and D. We will use berberine, or in some cases, we do use metformin. DIM is always a part of it, and then melatonin and HCl tablets. In the 60s to 80s group, these women have been in menopause for 1 to 3 decades. They can still have adrenal fatigue, and definitely decrease in melatonin and stomach acid. So the big thing with these females are they're dealing with comorbidities that go along with menopause, breast cancer, heart disease, osteoporosis, Alzheimer's. A lot of times they will have cruised through the hot flashes. They're not really having that anymore, but they're starting to deal with the big symptoms of aging. So I want to bring up the fact that sex hormones increase nitric oxide, and nitric oxide is really the hero here because it gives the hormones this is why we have hormones, and it's the fountain of youth. because increasing nitric oxide will increase the flexibility of our vascular system so that more blood flow occurs. You're getting more oxygenation and more micronutrients to all the tissues and cells. So if we go around this little circle, nitric oxide from the testosterone and estrogen helps to increase energy. It definitely increases blood flow to all the vital organs. It helps boost exercise performance and endurance, helps to manage diabetes, lowers blood pressure. It can reverse atherosclerotic plaque formation, improve sexual performance. This is why testosterone therapy will increase for females, just like with males. It helps increase the sensitivity, the blood flow, all that stuff makes sexual performance better. Enhances memory and cognitive function, etc. So nitric oxide is the hero here. Just another demonstration of estrogen as we age. You can see here it really hits heavy between the ages of 35 and 40. That's when estrogen dominance occurs, where a lot of the trouble starts. Fibroid cyst, fibroid tumors, fibrocystic breast tissue, breast cancer, uterine cancer, all those things, because we are not having adequate amounts of progesterone and testosterone anymore. So the treatment for the 60 to 80-year-old group, this is where it's a little different. We're going to, because of the effects of nitric oxide, we're going to go lower and slow with these patients. So we might do a 5 milligram compounded testosterone cream as opposed to 10. The pellet dose may be half of what would be recommended for a patient that is younger, that's about the same size and activity level. We'll do about half the dose of Biest or half the dose of estrogen, just to get these patients started. Once they've done one round or 4 to 6 months on this level of therapy, if you feel like you can afford to go up on those people, we certainly do in our clinic. Progesterone is the only thing that we keep at a higher level of 100 milligrams capsule or 10 milligram progesterone cream. We will still utilize all the good stuff, DHEA, methylated Bs, berberine, etc. For adrenal fatigue, Access Medical Labs has the next gen adrenal panel. It's a saliva test, which is fantastic. It allows you to get 4 cortisols throughout the day, because as we wake up in the morning, our cortisol levels are the highest. About noon, it should be about half of what it was when we woke up. About 3 or 4 o'clock, 5 o'clock, it'll be about half of what it was at noon. And then it should be the very lowest at bedtime, which should be around 9 or 10 p.m. So there are typically 3 stages of adrenal fatigue. In stage 1, your adrenals are still healthy, so they're going to produce a lot of cortisol. There's a pregnenolone shift that shifts towards the cortisol side of things, and that's going to decrease the ability for our adrenals to back up our sex hormones. After we've been in stage 1 long enough, stage 2 occurs, and then we have decreasing levels of cortisol and DHEA. So when you're looking at your cortisol results, if your levels are high, but they're feeling some fatigue and things, they're probably stage 1. If cortisol and DHEA are low, also pregnenolone is low, that will be stage 2. And then typically you don't see a lot of stage 3 adrenal fatigue in your office. Those people are their life is being threatened basically, and they need hospitalization. So what we do for our adrenal protocol patients, after you get your saliva test results, methylated B complex is super important. Mineral supplement is very important. And then we will add 1 to 3 milligrams of pregnenolone and 1 to 3 milligrams of DHEA. Thyroid health, if we look at um, uh, the thyroid is a big piece of hormonal balance. And so once we've gotten these results, we try to keep these things in mind. We're going to replace T3 and T4 typically in our office, especially. So that means that you're going to have things like Armor, NP thyroid, WP thyroid. A lot of our patients will come to us on levothyroxine, and if they're married to that concept, we'll leave them on their level, but then we will add 5 to 10 micrograms of cytomel or liothyronine to their levothyroxine. And what that cytomel is T3, levothyroxine is T4. So you're giving them the combination of those two. But what are some factors that decrease conversion of T4 to T3? Dieting and stress, micronutrient deficiencies like zinc, selenium, and iodine, and then even some certain drugs like beta blockers. So our goal for when you're looking at your thyroid panel, we would like TSH to remain below 1.5 to 2. We want free T3 to be above 3.5. And then TPO antibodies, we would like to see below 30. Gut health is super important. Once again, 80% of serotonin is made in the small intestine. It takes about 6 months for the intestinal flora to heal from one antibiotic. So we don't just throw antibiotic around. We wait till it's super necessary. And then food sensitivities can cause leaky gut. And then once you have leaky gut, you have all these antigens running around in your bloodstream. And then that causes an autoimmune response that takes it looks like psoriasis. It can be the cause of Hashimoto's. Um, so what Access Medical Lab offers is their IgG food sensitivity panel. It tests 286 foods. And then also they offer stool testing. So you can get down to the bottom of what microorganisms is that patient dealing with. So healing the gut by removing the food sensitivities is big. And then adding pre and probiotics, adding things like L-glutamine and amino acids so that intestinal wall can heal. And then if you're dealing with a patient that has yeast, candida cleanses are available, and there's definitely certain things you can get rid of microorganisms once you know what they are. So that brings us to the end. Thank you, Leo, for managing the PowerPoint, and I'm going to turn it back over to Leo.
Absolutely, Dr. Kelly. It has been such a pleasure, such an informative lecture, and we actually have quite a few questions. I am going to very randomly ask them, okay?
Okay.
Okay, let's go. So the first question, testosterone creams may cause hair growth where it is placed and could potentially be transferred to others. Females don't like this. Would injecting be better? And what dose do you like for your injections?
Okay, that's a good question. And I agree, you do have to be careful, especially transferring testosterone to children, even to pets. A male partner would probably appreciate it. But as far as injectables for women, we don't do that a lot in our office. However, and the reason being is this, we try to keep everything bioidentical. And what testosterone cypionate and xanthanate, propionate, all those things are a little bit harder on the liver. Liver has to cleave those salts off to use it. And so I say all that to say we do offer some injectable testosterone to our male patients, but I have to say I can't speak knowledgeably about a female testosterone dose.
Fair enough. And Would you initiate hormone therapy on a woman between the ages of 60 and 80 who has previously been on hormones but has been off for a few years for reasons unknown?
Yes, we do that all the time. My mother-in-law is 82, and we started her probably 10 years ago. But once again, that's where you're going to want to go low and slow. And a lot of times, if they were on a patient that age, if they were on hormones previously, chances are they were on the synthetic type, Premarin, Prempro, um, and the WHI study kind of scared a lot of women off of those types of hormones back in the day. So the answer is yes. You would treat that patient just like any other female. However, when it comes to the treatment phase, we start low and slow, meaning about half of what we would do for somebody younger.
Excellent. And as a part of your treatment, do you rotate the sites in which you have the patients apply their cream?
Yes. What we tell our patients on creams is to use the underside of the arm, the upper chest, the inner thighs. Just you're going for places of the skin that don't have a lot of hair on it. It might be thinner. And then especially with progesterone, where if they want to put that on their upper breast tissue, that's a good place for it as well.
Excellent. Now, moving on to hormone therapy and contraceptives. So, will giving testosterone to females on an oral contraceptive change the effectiveness of their birth control?
That has not happened to us. And because the ovulation is still going to be suppressed, the mechanism of action, I guess, would be that they would have to convert some of that testosterone over to estrogen. But the FSH is nice and low on a birth control pill. And it's clinically, that just hasn't been a problem. I'm not saying it couldn't be, but that is a good question. But clinically, we just haven't seen it be the case.
Fair. Now, moving on to DHEA. Is DHEA, or would you recommend DHEA to be administered as a transdermal or an oral med?
So I've used it both ways. We've had sublingual DHEA where you just use um, the underside of the tongue. There's a lot of absorption that through the capillaries there. The oral, anytime we take anything orally, we only get the advantage of using 20 to 30% of it. So I like having DHEA in a cream or a sublingual more than an oral.
Fair
But
enough.
it kind of just helps whatever you can get your hands on.
Fair. And would you agree that, depending on how the patient is reacting, right, to the medication, you would prefer one over the other?
Yeah, like if we can't, and here's the other thing is if you're doing something with creams or sublinguals, a saliva test is going to be much more accurate than a serum test. So a lot of times, if you're just doing blood work, you're not going to see true levels of those hormones, and that could be, any of it: estrogen, progesterone, testosterone, DHEA. Saliva really is more accurate.
Excellent. So you recommend saliva for the sublinguals and then blood tests for the injections.
Injections and pellets.
Excellent. Now this is a very unique question. If there's a patient who is currently undergoing menopause and they're on pellets for progesterone and they're also at night, do you suggest doing 2 weeks on and 2 weeks off of the medication to not cause any sort of concern with bleeding?
So that's a great question. And what we do if the patient has been in menopause, but she's on pellets, and those are the patient, we always keep our progesterone exogenous. We never put it in our pellet because progesterone is a very calming hormone. It can make the patient sleepy. So we keep it either in a cream or a capsule, but we will have that patient do their progesterone every single night if they are concerned about bleeding. And
Excellent.
that's where we handle that question up front.
Perfect. And do you have more time for one more question, Dr. Kelly?
Yes.
Okay. And are you open to answering? I know this presentation was regarding women and women hormones. Are you open to a question regarding a male and male hormones?
Sure.
Okay. So this individual has a 29-year-old patient whose testosterone level is 216. Wow. Would you recommend hormone pellets at such a young age or DHEA sublinguals?
So because of the patient's age, we have to have a conversation with that patient. If they are still interested in possibly fathering children at some point, what we've done with a lot of our guys that age, because unfortunately due to stress and diet and the world we live in, testosterone levels aren't what they used to be in young guys. And so we used to use HCG to help create their own, increase their own production, along with weightlifting, high protein diet. All those things help raise testosterone naturally. But now we use Clomid in place of HCG. So I've seen clinically guys on Clomid, their levels stay about, we in the 900s. So there's that option for that young guy, or you can do testosterone pellets, have them do a round, and then do a round of Clomid after the pellets. Especially what I'm thinking of, one patient in particular, they knew they were about to try to get pregnant. So he went off his testosterone pellets. We did a round of Clomid with him. His own testicular production was high enough that she was able to get pregnant. So that it's just the discussion, because once you add testosterone, their own production is going to decrease, and you'll have testicular shrinkage and all that good stuff. So you just really need to manage that patient's expectations as far as his sperm count goes.
Fair. So all in all, you would say, let's try to change your lifestyle, your diet. Let's put you on Clomid, maybe HCG, and then if that doesn't work for this specific patient, possibly put you on pellet therapy.
Yes, yeah.
Okay, excellent. Well, Dr. Hopkins, that truly wraps it up for us. We at Access are so grateful to have had you on this Access Live. The lecture was amazing. I wish we had more time. We have about 50 unanswered questions in the Q&A. To the viewers, we will be posting the video on our YouTube channel, so you will be receiving a link here within the next coming days. Dr. Hopkins, any last words?
I would just offer myself as a resource through Access, if anybody really needs more help beyond this webinar.
Excellent, absolutely. We thank you again for your time, Dr. Hopkins. To our audience, thank you again for tuning into another Access Live, where we bring you insight from leading medical experts. Please don't forget to like, subscribe, and we'll see you next time.
Thank you.